Welcome to the MedConceptions podcast. The following is a podcast with Professor Faye Gishen, the director of UCL Medical School, a palliative care physician, a pioneer in medical education, and a mother. We talked about all the new changes that are happening in medical education, the things that could be better. And we also went and spoke to UCL medical students to see what it feels like to be on the battlefield. I hope you enjoy it. I'm here today with Professor Faye Gishen. Thank you so much for being here today with us.
Thank you for having me.
It's a pleasure, and I feel privileged to be here because I don't know if you hear it a lot from us, but we do look up to you.
Oh, thank you.
And I think let's get right into it with the first question, which would be, what do you think it's, from your experience, one of the most innovative things that we've had in medical education in the recent years? And then one of the things that we can work on.
So probably one of the really big shifts has been sort of widening access to the people who study medicine. So I think traditionally medics came from quite a select, maybe in inverted commas, elite group, which felt closed to some members of society. And I think it's really important that the doctors of the future, the doctors of tomorrow, map to the citizens that we serve. So there's been a really mindful and strong move in medicine to widen access, to have medical students representing and coming from everywhere and representing everyone, representing society. So I think that's been quite a big shift, and it's a shift for the good, particularly as it's going to be more representative of patient populations. Other sorts of changes I think we see mirrored elsewhere in society. So a move to think more about technology, artificial intelligence. There's a huge amount going on at the moment, as you know, around Doctors of the Future, the NHS long-term workforce plan, how we can grow doctors to practice in the changing systems of healthcare in the NHS. But yeah, I mean, I think we've got to stay modern. We've got to stay contemporary. We've got to read the writing on the wall for society. We've got to be speaking to the sort of big civic duties that we're training to serve patients around.
Have you felt that with this change in diversity as well, that not all students come from this elite background, that the culture also in the medical school or the needs of the medical students have changed? And if so, how do you accommodate that?
Yeah, I mean, that's a very pertinent and relevant question for the times. I mean, when I was a medical student, we were fully funded through medical school. So I didn't accrue the same levels of debt, and my contemporaries didn't accrue the same levels of debt that medical students and other students do now. I think what we've done is we've worked to really diversify the curriculum to reflect the areas that we spoke about before and to reflect patient populations in a city like London, which is metropolis, and beyond. And I think the sort of diversifying element is really important. Are we modern enough? Well, we can always improve. We've got over 2,000 students at UCL at any time. So we can always be improving. We can always be changing. We can always be modernizing. But actually, the longer you're around this, you see that things sort of come around in a circular way. So things that were there when I was a student about being more transparent around assessment and those sort of things, they're still here.
Yeah.
And it's difficult because I think students don't always, I wouldn't expect them to be really interested in things like governance and what goes on behind the scenes. They see something, they think it might be unjust or it could be improved. And maybe the pace of change or the appetite for change doesn't always meet students' expectation. But, we're always working behind the scenes and we're always trying to keep our eyes on the big picture and on students.
Yeah.
Absolutely. Students are at the core of the decisions that we make, as are patients, because they're the ultimate recipients.
Yeah. What you said about governance is interesting because I was talking with a professor from Crete at a university and medical school there. And he was saying how important policymaking is right now and how important it is to include that in the medical curriculum, because with global change as well and how things are evolving constantly, you also need medical and healthcare professionals, doctors, to be involved in these policies. We have to be part of them. So I'm sort of grateful to hear you say it.
I really believe that, I mean, we're operating in a very academic institution, and everything we do needs to be underpinned by evidence. Yeah. And whether that's education, which is evidence-led, research-led education, or it's policy, things need to be underpinned with rigor, with data, with evidence. And so I think everything that we do as an academic institution should be underpinned by best evidence that's available across the board. And I think policy is going to be one of those really big areas for us in the future.
And you also get advocates because when you have doctors who are in the profession and they know what's going on, they know the everyday struggles, they're also your advocates when they're there talking about the big policy changes that are happening. And I think with what's happening with junior doctors right now, I think we're in need of strong advocates.
Sure, I agree. And I think it's a challenging time for healthcare professionals. I mean, I still think the NHS is an amazing institution, and we're really lucky to have it. And when it works well, it's absolutely phenomenal, world-leading, brilliant. But what happened during the pandemic and the size of the population mean that it's absolutely not perfect. And I think it's a challenging time for medical students, nursing students, healthcare students, and also qualified practitioners. And I know our students are subject to things that they hear doctors and nurses talking about on the ward. They're not immune to feeling nervous about qualifying into the system. We know that, we can't deny that some practitioners leave and go to try working in other climates and other countries. Yeah. But a lot of them come back because I think at the core of us is that sort of professional desire to serve patients. And I'm super, super proud, I am, of our students. Yeah. And I think, people go into it for all the right reasons. They want to look after patients. Well, you know that from a lot of the work you've done around compassion. But there are challenges, and it's not an easy climate and landscape to be qualifying into.
I was reading an interview you did, I think, with one of the UCL entities, and you said that you had this experience with two healthcare professionals. I think doctors came up to you, and you overheard them saying something about a medical student, and how they were like, oh, because he was compassionate, etc. He had good patient manner. They were like, he's probably a UCL medical student.
This is true.
Yeah.
Yeah, I mean, it does happen, and it sort of does make me sort of feel very, very proud. But I think, all the UK medical schools do a really good job, and we all turn out very proficient, capable doctors who meet all the skills, etc., the outcomes for graduates. But I do think there's something about UCL which perhaps because my predecessor was a primary care doctor, and she really brought that lens to our educational offering. I do think that we set a lot of onus in our curriculum on clinical and professional practice, so clinical communication, ethics and law, etc. And we've got an amazing clinical skills team, as you guys know.
Indeed, big shout out to the clinical.
They're amazing. They're
team.
Amazing.
Both I was at Royal Free with Emma Thompson, and now Thompson, and now at Whittington. Both, they're
fantastic, and they know all the students by name, and they make the environment very civil and very pleasant to learn in.
Before we came here, we wanted to talk to medical students, and from all over. So we went in Cruciform, and we were doing short interviews with medical students and asking them what they liked about the medical school and what they didn't like about medical school. We'll post some clips as well. And one of the things that...
Should I be scared?
No, I think it was... I think you'd be impressed. One thing that came out as an area of improvement for first year medical students was the need to feel more connected to the staff and what's going on and etc., which is normal for a first year or second year medical student. But later on, when they go into clinical years, you have that connection with the clinical teams, clinical professional practice teams.
Yeah.
And that's nice, because there's
Really
a
nice.
team down there
Sure.
who know you by name, who are your we have these, I forgot the name of it, when you have like a not supervisor, but
a personal tutor.
A personal tutor, and
Right.
who are usually your personal tutors, and that you can go and find them, and you have this connection, and you don't feel just like a number. Because I think one of the challenges that big universities face is that you become a bit lost. You're like, I'm just and yes, I'm.
Yeah, I mean, I think there are much smaller medical schools in the UK where, different schools have different brands, different selling points, different flavors. And, UCL's a big one. It's not the biggest, but it's really big. And I think what you say about belonging is really important, and we're aware of it. And I think it is important for faculty and for teachers to make themselves very visible to students and be accessible to students. That transition from school is a really tough one.
Yeah. And that's also where the RUMS comes in.
No, totally. Totally. I mean, RUMS is absolutely the heartbeat of the medical school, and a lot of work that they do around cohesing us all together, and the social elements, absolutely indispensable.
So for those who don't know, would you care to say what RUMS is or what it does?
Yeah, it was formed when the different medical schools that make up UCL Medical School happened, and it's our student society, and it's got lots of different society groups and clubs that are under it, and it's got a leadership team that's nominated and voted for every year. Those rounds are about to come up again. It's a big job to do that. Some universities have a sabbatical post to be president. We don't, so people do it alongside their studies. They're usually clinical students in the clinical years, and it's just an amazing organisation. I've learned a lot from RUMS, and they really sort of are that glue that holds the medical school together.
It's important. It's again the feeling of belonging, and the feeling that this is my medical school.
Yeah.
I'm playing football for my medical school. I'm playing rugby for my medical school. It's important. It's a sense of community, which is good to be fostered. I want to go back to the person-centered skills, where you said, so what is it that I guess UCL Medical School does, or what can it also improve when it's teaching these virtues? And I think it would be a good point for me to introduce the following. I conceptualize teaching in three categories, and I think we did touch upon this the last time. One is the knowledge that you have to learn, the stuff that's in a book that you have to regurgitate. It's tough, but it has to be there. And then you also have the practical side of things, where it's the hands-on procedures, where how to suture, how to clean a wound. And then you also have the experiential stuff, which is the virtues of creating someone who isn't only a question bank, but is a person.
Yeah,
is someone who can relate, understand, and have a motivation to treat a patient.
Sure.
And I think we struggle a lot with teaching experiential stuff. We've become very good at the practical and the knowledgeable. I do want to get your thoughts on this, and what can we do to improve that?
So much of becoming a doctor is literally the becoming, in inverted commas. And that's what happens for our students. Over 6 years at UCL Medical School and beyond into practice, I literally learn from patients in every clinic. You're absolutely right. There's all the stuff laid out by the regulator, the GMC, who we have to account to for our program. So there's all the hard science, which, by the way, is easy to examine, and lends itself well to single best answers and things like that. But then there's also, as you say, so if you look at it pedagogically, which means sort of from the science of learning, there's the formal curriculum, and there's the informal curriculum, then there's the hidden curriculum, which is really potent as well. And it's about sort of attitudes and the sort of underlying culture of a place. And yes, we're pretty good at teaching the formal curriculum. especially the hard science. And I always say, the soft science, the soft skills, which can be a bit more challenging to assess, are the really, really important ones. You can teach the hard science, and that's very important. But the soft skills are what we remember when we go to the doctor, how somebody communicates with us, how they put us at ease, how they make us feel, how they enable us to open up and be honest and earn trust. And those soft skills, and the word soft is a little bit pejorative in a way, isn't it? Those are the things that I think our curriculum at UCL focuses quite heavily on. And actually, what I've been quoted as saying before is paradoxically, the soft skills are actually the hard skills. But it's true, isn't it?
Yeah, it is.
You can learn the course of an artery or a nerve, or you can learn how to suture, and those have their challenges as well. But it's how you make a patient feel. It's how you build a trusting relationship with a patient. It's how a patient knows intuitively that you're somebody who's going to keep their confidence. And those soft skills are absolutely paramount in a doctor. And of course, we could teach and learn better, but I do think our curriculum places a lot of store, and we look for those attributes at interview, when we interview very selectively and competitively for the future UCL doctor.
That's interesting, because you also have baseline when you're picking medical students who also show those attributes as well. It's not just that you've taken someone from level 0 and taken them to 100. You've also picked the baseline of, which is, I'm very pro of that, because that makes it an area for people to focus. Yes, being a doctor isn't just about knowing all the hardcore science, but it's also knowing all the evidence-based soft skills. I want to say that as well, because it's evidence-based. We're not here discussing about something that's an add-on. No, it actually makes a difference in patients' care, and we know it does.
Undoubtedly.
Across the board. Yeah,
absolutely. And we know how we feel when we go as a patient.
Exactly.
We're all patients. How we feel when we go and see a doctor or a nurse, a healthcare professional, when we're unwell, feeling vulnerable. And of course, our students are amazing. Not only are they smart as can be and academically very able, but we're also looking alongside that for that complementary skill set, somebody who can communicate well, who can make a patient feel okay or better. You can't cure everything for patients. We know that. As a palliative care doctor, I know that.
Yes.
You know that. You know there's so much around long-term conditions and complexity. But it is about trust, and it is about how you communicate with people.
How do you teach and how do you assess that?
Good question. Not what our students love to sort of be signposted to stuff, but so much of what you learn is not necessarily formally taught.
Hidden curriculum.
Well, it might be hidden, but it might just be watching role modelling on the wards or in primary care. It might just be seeing something well done or perhaps not so well done, and sort of picking up those skills, thinking about, I know medical students don't always like the R word, reflection, but it's about seeing things, picking up how you work as a practitioner, thinking about what you've seen done well, maybe not as well, and thinking about the sort of doctor and practitioner that you want to be. How do you assess those things which can be taught and learned? Well, you assess them through things like integrated stations in OSCEs, CPSAs. So, very rarely you're in a Viva-esque situation with a one-way dialogue. It's complicated. There's a patient who's feeling vulnerable, whilst they might have X medical condition, or there might be, Y other person in the room. It's rarely a sort of binary set of things to learn. It's often just a complex milieu of a clinical situation. We try to mirror that more and more in our assessments.
I think that's super important. What brought you here?
I don't love talking about myself, but I'll have a go. Like you, Andreas, I'm the product of a doctor and a teacher.
That's so true. I clocked that as well. That I didn't clock the teacher part. But yeah, my mom was also a teacher. Yeah.
So I suppose medical education was in my blood, but I knew I wanted to be a doctor when I was about 8.
How colours?
Not sure. Role modelling, just feeling intuitively that that's what I wanted to do, to look after patients. And then I got to combine looking after patients, which I still do, with this sort of deep joy of helping produce the future doctor. So, I mean, it's a marriage made in heaven. To be able to sculpt the learning and the future careers of thousands of people is just amazing.
Yeah. How did your from going to I want to be a medical student to now being the dean of the UCLMs, how did that happen?
Oh, it happened through taking opportunities. So I was just I was a standard consultant.
That's so interesting, by the way.
No, you're right. That's what I did. I just saw patients, and then
Yeah.
something opened up. And I've had amazing mentors along the way, people like Jane Dacre and Deborah Gill, who were previous heads of schools.
Mm-hmm.
I had my parents, I had other clinicians and other nurses and people that I'd met along the way who sort of helped shape what I wanted to become. And then I just worked my way up. I did a doctorate in my 40s, which is not an easy thing to do with a large family.
You have 3 children as well.
I do.
So, yeah.
I do, and I was always part-time. But, you know, where you have strong goals and the right support mechanisms and networks around you, you know, I've been lucky and I've worked incredibly hard. Not necessarily harder than the next person, but in a way that I've taken opportunities. And when this role came up, you know, it's just an incredible job. What can I say? I'm really lucky.
Would you change anything about it?
No, not really.
I find it fascinating that you have so many experiences from which you can draw and cross-pollinate in the different sectors that you're working in. And I do want to hear your thoughts on that. Do you think it would have been better if you focused on one thing, or the fact that you have all these things going on at the same time? Because I also I want you to clarify that being the director, it's not just about the UCLMs. You also have other fields that you work in.
Yeah, I mean, that's the, so portfolio careers, having more than one sort of string to your bow. And for me, it's leadership, clinical work and education, as well as some research. You know, you can risk being jack of all trades and master of none. But if you curate that carefully, I mean, portfolio careers in medicine started in primary care. And we're only just catching on in secondary care, really. But what a portfolio career does for me is it's very nourishing. So I really enjoy seeing patients, and I also really enjoy the leadership elements. I really enjoy the pedagogy and the education, plus being able to do research. So I got asked actually in my interview a few years ago for this job, what sort of I would bring to it. And actually I can say, hand on heart, that probably the skills that I've learned from being a parent and the skills that I've learned in having challenging conversations in palliative care are probably the 2 most valuable things that I bring to this job. So, you know, it's not always easy having difficult conversations, but what palliative care has done for me is it's taught me to, I hope, sensitively have them and face them. And that translates very well into this sort of complex environment, running a medical school. And similarly, being a parent, you know, you pick up some really important stuff, some stuff about compromise. And my team always laugh at me. I've got a few leadership phrases that I use. And one of them is this a hill to die on or a hill to roll down? In other words, you know, you can't go to war over everything, nor would you want to. And some things you have to really fight for, and other things you just have to think, this is not worth, you know, scrapping over. I'm going to roll down that hill.
Yeah, I remember this. I don't remember who told me, but it's the same thing. But an amazing general picks his battles wisely, and it's the same thing. Yeah, you have to have the discretion to know when to.
Yeah, and maybe students would disagree and they'd think I, picked the wrong things. But in this sort of job, as you alluded to, you're not just working locally, you're working at a national level. So you sit on, bodies like medical schools council, and you see what's happening across the terrain, across the landscape of undergrad med ed. You interface with NHS England, even at government level. So one day I'm facing patients, the next students, the next NHS England, the next Medical Schools Council, or you might be looking at research bids and how to bring grants in. So there's a huge breadth. But I go back to the fact that my most valuable skills that I've learned have probably been through being a parent and being a doctor.
I think that's incredible. And there's a lot to be said about a portfolio career, because I think in the media in the last 20, 30 years, maybe even more, we have glorified specialism. Some people might disagree, but I feel like I grew up watching movies about a surgeon who was amazing at doing this procedure. And it is, and I'm not devaluing it now. It is an amazing thing to be so specialized in everything about something. But at the same time, this specialism is supported on the backs of the generalists. If the generalists fail to do what they need to do, which is, and generalists, I think, also prepare the next generation of specialists, which is also interesting. Then you have a system which struggles to function.
Yeah, if you listen to all the sort of influential scholars and people in education and in medicine and medical education, generalism is absolutely key. That there is evidence to back that up through things like the WASH report. But if you listen to people like Chris Whitty talking about it, they talk about generalism. And you absolutely cannot have a functioning medical system or medical education system without putting that right up there. Generalism is the lifeblood, and it is if you want to see it as a specialism, you can. Lots of primary care physicians and GPs will refer to general practice as a specialism, but it is a specialism of generalism. And it is the absolute lifeblood of the healthcare system and of medical education.
I've got a bit of a controversial question. What do you feel with what's happening with the foundation year programs now? I don't want to put you on but yeah.
I think, some of this job and some of leadership is about diplomacy. And you were speaking about this at a time where there was an announcement last week.
Yes.
So it's very hot off the press.
Yeah.
And I absolutely understand why people are concerned about it. I better not say too much at this point, because it really is an evolving area. The sands are really shifting. But we are in a very academic institution, and students work very hard to try to distinguish themselves and forward their careers. And I totally see some students' perspective on it. I think nationally, some of the drive behind it is laudable. It's about opening up access and giving people equal opportunities. I see that perspective, but I think our students will be challenged by some of the decisions. And let's see what happens.
And for those of you that don't know, basically what happened is they made it a random process of who's going to go where. and everyone's going to have the same chances, and extra degrees or extra publications, etc., won't matter. I'll say my opinion. I'm basically no one. I'm a medical student. I just, from the way I see it is, I feel like when you remove you remove an incentive like that, it's hard for someone who's in medical school to strive for excellence, and you end up with mediocrity. And it's not that. Yeah, I don't know.
It's a tricky one, isn't it? Because the country is trying to get more doctors into under-doctored areas, which tend to be rural or coastal, and that's really important. I think the thing that, correct me if I'm wrong, but I think the thing that students are worried about and students feel is the same as what patients feel. People want some agency, some autonomy over what they perceive happens to them.
Yeah.
And this has been happening a little bit over the past few years with the disappearance of the EPM, and the situational judgment test, and it's being flattened across the board, and that's got advantages and also challenges. And I think my students are worried that some of that autonomy is disappearing for them. That's how they feel.
And I guess from the perspective, let's say you want to have a family. It's hard to go into this and I don't know where I'm going to be next year, because I don't have that autonomy over that. And that's kind of being taken slightly. And I think that also makes the medical field a bit less attractive to prospective medical students. But we can go on about this.
I see that. I mean, I think there was always an element of, you couldn't always completely control
where you're going to be,
where you went. There was always that element, but I think the perception is that's been eroded, and I totally get what you say.
Yeah, I want to talk about role models. What have been for you, number one or two? You can talk about as many role models as you want in your career. And why have they been role models for you, and what have they taught you?
I mean, it's hard to pick a couple, but if you really pushed me, I would definitely choose my dad he's still in practice.
What? How old is he?
He's cracking on, but he's a radiologist, so he's not directly patient facing, but he's still in many ways, he's a generalist now in radiology, and he loves a plain film. And there might be sexier stuff on the block, but he's just, he remains really true to his craft and his art, and he remains very interested in patients and patient outcomes. So he's got to be up there. Probably put my mum in that basket as well. And then I've had a couple of clinical colleagues who've had a real impact on me personally, how they've interacted with people, patients, colleagues, how they conducted themselves. And then I've had definitely some role models in medical education, people like Dame Jane Dacre, Professor Dame Jane Dacre, who remains in a sort of very informal mentoring role for me. And I also see Deborah Gill, not infrequently, as the previous head of this school. And they're people who are very aspirational and inspirational. And, they role model integrity and good values and all the things you and I look for in I can see some of this resonates with you. we look for, of course, you're thinking about your own father and your own parents and, the role that your mum would have played. I think there's some amazing role models around. You just have to keep your eyes open. We're all shaped by people that we meet across the way.
Yes. I feel that sometimes. We are. And I feel that sometimes in the medical, when you're in medical school, you have to also go looking for these role models. Sometimes you're fortunate enough that they appear in your life, and it's maybe a father, a mother, or it's someone, a relative. But I guess if you also need to want it. You also need to go out there, and if you see someone who's there, knock on the door, and maybe they'll answer.
You're so right.
And they'll be like, yes, come and join me for 1 or 2 consultations.
Yeah.
And when you do that, I guess people feed off your excitement as well. Like if you're excited and you're motivated and etc., then the person's actually going to invest some time in you as well. Because I don't know, do you have like any, I guess, advice to medical students or who are looking to be inspired? Because many of us, I feel that many medical students are not inspired.
Well, that seems like quite a positive note to end on, because I've been bending your ear for probably half an hour now. I think, I mean, our students never cease to amaze me. I cannot get over the dexterity, the ambition, just how smart. I mean, somebody could be singing in a group. They could be working in target medicine to inspire the next generation of students. They could be playing rugby. They could be, in doing things as an influential student president or a future medical leader. I mean, I'm constantly amazed and inspired by the students, my own children as well. I would say, try not to put too much pressure on yourself as a medical student. If at first you don't succeed, keep trying. It's honestly, it feels catastrophic at the time, but if you end up retaking an exam or, not getting the BSc that you wanted, or something, it's honestly of no consequence in your life. It really doesn't matter. I've made other podcasts where I've talked about things that I've failed, and not everything sort of comes on a plate easily. That's not how life is. We end up seeing the end result a lot of the times, and we think, but try and just have fun along the way. Medicine is really fun. It doesn't always feel that way, and there are really hard times in becoming a doctor and being a doctor. There's no doubt about that. But it is an amazing, amazing job. It's such a treat to be a doctor, and all the things that you can do under the umbrella of medicine. I mean, I can't think of anything better. I love that. And I do want to end it now, but I have one more question. What are you looking for in prospective medical students here at UCL? Yeah. I mean, I think at the end of the day, I'm looking for what most of my colleagues around the country are looking for, which is somebody who's going to be of course, a clinically competent, that's super important, but also a kind and compassionate doctor who's going to earn patients' trust, who's going to be trustworthy. At the end of the day, I'm looking for a colleague, future colleague. And maybe I might get a few medical educators along the way as well who are inspired to lead and teach the next generation. But I think, the long and short of it is we're looking for really good people who have got good people skills, and they're going to be trustworthy and kind doctors. Amazing. Thank you so much. Thank you so much. Pleasure. Thanks so much. It's been a pleasure.